Good afternoon, everybody. It's my pleasure today to present the glaucomatous optic nerve head examination and finding. Optic nerve is an important organ in the eye. Everyone should know the normal optic nerve and the abnormal optic nerve. Whether you are in your general ophthalmology clinic, you are in cornea clinic, in glaucoma clinic, you should know the glaucomatous or glaucomatous suspicious discs. So our presentation today will talk about the optic disc changes which can happen in glaucoma discs. As you know, all of the open-angle glaucoma, especially the primary type, is an optic nerve. So the main pathology will happen in the optic nerve. So in order to know, we need to know the changes happen to the head of the optic nerve. This optic neuropathy is progressive, as you know all, due to damage which happened to retinal ganglion cells and their axons. There is a specific pattern of the optic nerve cupping. Usually, it's associated with the other finding and signs, like a visual field defect, especially when finding the ancillaries. There is structural and functional damage can happen to the optic nerve with the progression of the neuropathy of the optic nerve. Nerve fiber layer injury can be observed up to 6 years before the visual field defect. So it's very useful to check for the nerve fiber layer, especially in the cases of glaucoma suspicious. Mean number of axons in every optic nerve is about 800,000 to 1,200,000. 25 to 40% of the optic nerve fiber can be lost from an eye that retains a normal visual field. Regarding the structural damage, can affect also the functional damage changes. The visual field loss by the subsystem does not mean early disease. By the time visual field loss is detected by subretinal, substantial structural damage may exist. Optic nerve hair assessment is useful to detect glaucomatous optic nerve hair damage earlier and very useful for the follow-up to detect any progression in the disease for the diagnosed patient. Always it's useful to differentiate various types of glaucoma and can give a hint about the pathogenesis which is happening in the disease. In the examination technique, can use like direct, indirect, and the slit lamp biomicroscopy. We can use the different type of lenses like the Goldman 3 mirror, the Horby lens, the plus 78, plus 60, plus 90, and the photographic techniques. Optic nerve head in the glaucoma. We will talk about the normal and the disease type and some differential diagnosis of the optic nerve disc changes. We're talking the normal optic disc first, then size and shape, new retinal rim, optic cup, bezels, and the macrobrose and perivelar region. Let's talk about a little bit about the surface anatomy of the optic nerve. As you see, this is the new retinal rim. This is the most important finding you should look first when you look to the optic nerve. In addition to the cupping, this is the nasal side, femoral side, and this is the cup margin, and this is the disc margin. Optic disc size is not constant between people. It's different from one to one. There is very much individual variabilities. It varies from small disc, regular size disc, and large disc. Slight changes in the size we can detect in the +5 or -5 the diopter lenses. High myopia and hyperopic marked changes usually it happens and affect the disc. Usually in myopic patient we have larger disc, and hyperopic patient we have smaller disc. Of course, it varies with race. Caucasian have a smaller disc usually than the Asian and African. Asian and African, American, especially ancestry, have larger disc. The diameter, usual normal diameter, is about 1.7 to 1.8 millimeter for the height, for the horizontal diameter, and 1.85 to 1.95 for the vertical diameter. As we said, it's larger in African in the blacks. The surface area 1.67 square millimeter up to 2.69. We said 12% larger in the blacks. There is some small studies say that men has larger disc than women, about 3% difference. Neuromitral rim area is about 1.9 to 1.9 square millimeter. Male, it's vertically oval. When you assess the disc, usually we talk about the vertical and the horizontal diameter. Optic disc size, measurement of the optic disc size with biomicroscopy. Usually we use the lenses in the biomicroscopy, and we should put in regard that there is some change in the size for the Vogue lenses or the other lenses. For example, for the 60D, it's almost the same size. For 78, it's more than 1.1. For 90D, it's 1.3. You should put this in regard when you're calculating the size of the optic disc. If you have a large optic disc, reciprocally, you will have larger cupping. So maybe the problem not in the cupping, the problem in the disc. It's not actually a problem, but the size is big. So it's give you bigger impression that the cupping is bigger. As we see here, for a small disc, it shows a small cupping, regular or average about 1.9, and larger disc, here this is the story. Large disc show you cupping very high. If you measure the cupping here, it's almost the same disc of the small one. So if you don't, from the first impression, it shows you it's large cupping, but actually it's not large cupping, it's only a large disc. The small size could be any disc about 1.5. We classify as small disc, 1.5 millimeter, and any disc about more than 2.2 millimeter is a large disc. Myopic patient, as we said, they tend to have larger discs, and you should be careful about the peripapillary shows, which can give you a false impression of more larger. The shape of the optic disc, usually slightly vertical oval. It's not correlating with any age or sex, as you said. Abnormal optic nerve shape, corneal astigmatism, sometimes affect the shape of the disc. More oval disc come with the astigmatic patient, especially when they have larger astigmatism. The optic disc cup is the difference between the number of axons going through and available and the available size of the hole. Yani the cup is the area with empty, including the intracanalicular optic nerve. This is the cupping area. Optic cup in smaller disc, obviously there is no cup. Sometimes you see there is very, very small cup to the extent there is no cup. And optic nerve head change may be erroneously overlooked in small discs. Small discs often show glaucoma abnormalities in the peripapillary region, such as decreased visibility of the retinal nerve fiber layer. Diffuse or focal diminished diameter of the retinal arteries. We talk about a little about physiological cups. Physiological cup is a normal cup, normal disc which has a large size, and the cupping is a little bit larger than the average, can reach up to 0.7, and it's a normal disc. Usually it's horizontal more than the oval. For the new retinal rim, intrapapillary equivalent to the extension of the retinal nerve fiber inside the optic nerve. It's the main target we are searching about, considerable intravidual variabilities. It's correlating with the optic disc area. Large disc area has a large rim. When we searching for the optic disc and to diagnose to rule out glaucoma, one of the useful technique to search for the isintral. Isintral, it is classified as the inferior superior nasal temporal, as it is the larger inferiorly, then superiorly, then nasal, and lastly temporal is the smallest area of the rim between the edge of the optic disc and the edge of the optic cupping. The shape, it's broader inferiorly, superiorly, nasal as lastly temporally. This isintral has been proposed by Elliott and Werner. Early glaucoma predominantly inferior temporal and superior temporal region involved. Moderately advanced glaucoma affect temporally. Very advanced nasal disc also being affected. And if it's applied the isintral, usually it is a normal disc. If it's broken, usually it takes this is protocol. Sequence of disc sectors correlate with the progression of the visual field defect in the opposite direction of the visual field. For the retinal nerve fiber layer visibility appear as fine, feathery, silver striation for the normal person. If there is any defect, the striation is reduced or absent, or can be appear as a darker band. Better visualized with the green light or blue light, red free. In healthy eyes, blood vessels appear blurred because they are buried in deeper layer of the nerve fiber. In defective area, marked and sharp defect of the nerve fiber layer can be seen. Nerve fiber layer visibility, you can see merely most commonly in the inferior temporal, superior temporal, and nasal area in sequence. Optic nerve head changes in glaucoma, as I said, structural, contour, and the color changes, either being qualitative or qualitative. The quantitative, we check for the size, the CD ratio, the rim disc ratio, and the NFR height, right nerve fiber layer, retinal fiber layer height. For the qualitative, the contour of the new retinal rim, optic disc hemorrhages, peripapillary atrophy, and retinal fiber defect, and the pallor. For disc evaluation, we check for the intrapapillary characteristic, disc size and shape, for the cup size and the symmetry between the right and the left in the same patient, new retinal rim configuration and cup size. Lastly, check for the vascular changes for the vessels. For evaluation also, don't forget parapapillary characteristics like nerve fiber layer defects, any disc hemorrhages, vessel diameters, especially the large vessels, parapapillary atrophy, zones alpha and beta. The hallmark of glaucomatous disc damages is excavation. Step 1, we check for the size. Is it small, medium, or large disc? Everything give you a clue. If it's small disc, just go with the large size of the disc itself and the cupping itself. Check for is it round, oval, or abnormal disc shape. For disc shape, whether it's vertically oval, variation with the tilted disc, like the tilted disc, secondary elongation, especially in high myopia, disc shape influences the rim shape. Step 3, the cup size and asymmetry. Check for the symmetry, whether there is difference between the right and the left. Any difference up to more than 0.2 difference in the cup disc ratio is regarded as suspicious or pathological. Is the cup size rim appropriate for the disc size, as we said before? Cup disc ratio, CD ratio is normal, larger horizontally. But if it is being vertically more, this is going more with the glaucoma. For this cup size, smaller canal give you small cup, fibers bunched together, so a larger canal give you larger cup. As you see, CDR varies with the size, race, and age. Cup disc ratio of the disc diameter to cup diameter. Less than 10% of normal population, they have 0.5 or greater. CD ratio genetically determined. Inter-observer variabilities by the doctors. So it can be different, especially when recording the progression of the disease from different doctors. As we said, black Ehab has more CD ratio. Horizontal CD is more in the normal person. 6% having greater than 0.5. Difference in CD ratio more than 0.1 is only happened in 8% of the population. More than 0.2 displays in less than 1% of the normal population. This is an example for the disc changes in open angle glaucoma, although the disc is not large, but it is notching the area here. Here is the latter, the rim is intact all over the disc, so it's a normal, although the CD ratio is larger. The asymmetrical cupping, any 0.2 disc diameter or more is regarded as suspicious. in either axis of the disc. Discs are equal in size. Discs in different sizes, different, give you a clue for the symmetrical cupping between the both eyes. For example, this is the disc in the right eye and disc in the left eye. Here almost 0.8 or 0.75, and here almost 0.5, so more 0.2, it's a suspicious disc. For the cup and neural rim alteration, increase cup size, whether focal or concentric, increase CD ratio, alteration in the cup shape, vertical, horizontal disproportion, and asymmetry of the cupping. For the cup enlargement, either it's became unipolar from one notching side or bipolar. Diffuse loss of the neural rim can be localized area of the notching or can be diffuse generalized loss. A change in normal topographic configuration, selective narrowing in inferior and superior quadrant. Step 4, we check for the neuroretinal rim configuration. Where is the smallest rim width? For example, here we check for the changes which happening. There is some notching happening in the superior rim here. Localized rim thinning or notching, as is shown in this photo. There is superior notching. Another photo showing inferior notch. This is another example of advanced notching, advanced cupping. Another thing, we should talk about the color of the disc. The color usually will have large cupping. The disc color is getting paler, so it's getting more white. But if the color is exceeding the cupping, we should search for another reason or to rule out other reason of neuropathy, none other than glaucoma, if the color exceeding the cupping. Step 5, retinal nerve fiber evaluation. Usually we see with the red-free illumination. Is there any localized nerve fiber defect? Is there an overall decrease in the nerve fiber visibility? For example, here, if there's any defect, it can be slit-like. The defect here can be with shape, can be diffuse atrophy, or can be total atrophy, either in the one hemisphere or the whole fundus in the very advanced glaucoma. Some early nerve fiber layer defect can be seen here. Loss of the lustrelessness in the defect can be seen more clear in the red-free or the green ones. Can be with shape, defect. It's another defect here, more clear. Another defect here. Can be diffuse loss, almost there is no striation, can be seen in this advanced case. Here patient has small loss, but he has some nerve fiber layer defect. Normal nerve fiber layer more or less roll out glaucoma or any other ganglion damage. So local defect in nerve fiber layer can prove the damage. But doesn't prove glaucoma. Other retinal disease can cause also nerve fiber defect like a retinal scar, disc erosion, and other. Step 6, we can go for checking for the vascular signs, any disc hemorrhages, myoniting, other overpasses glaucoma. Disc hemorrhage, or Dar's hemorrhages. In glaucoma diagnosis, always look for the hemorrhages. Very likely to miss usually in the regular exam. In presence of hemorrhage, always rule out glaucoma. Patient suffer from glaucoma until proved otherwise. It can happen open angle glaucoma and more specifically in normal tension glaucoma. Differential diagnosis of disc hemorrhages, CRVO, diabetic retinopathy, disc erosion, any condition with disc swelling, etc. Hemorrhages in the glaucoma are adjacent, not an existing notch, indicate progression of glaucoma. Also can happen in progression of the disease. So it's useful for every checkup and follow-up examination to check for disc hemorrhages, which indicate there is a progression in the glaucoma disease or associated usually with visual field defect. It's an example of flame-shaped hemorrhages which happen in the fiber layer. This disc hemorrhage usually appear after it happens within 4 to 8 weeks and leave some visual field defect. Another photos showing disc hemorrhages, multiple disc hemorrhages. Another photo example showing disc hemorrhages. This is a little bit bigger, and this disc hemorrhages showing nerve fiber layer defect in the examination itself before you do visual field. Another finding, you can search for the parapupillary atrophy. We have the alpha zone and beta zone, hypo and hyperpigmentation area in the alpha zone present in normal as well as in glaucomatous eye, but it's not diagnostic for glaucoma because it can happen in normal person. For beta zone, it's an atrophy of the retinal pigment epithelium, or in other words, it can be a regression of the retinal pigment epithelium layer, and choroid capillaries can be seen. The choroidal vessels and the sclera become visible under the retina. More common glaucomatous eye. Beta zone itself also, it's not a pathognomic for the glaucoma, but if the size of the beta zone getting increased with follow-up, this is with follow-up for the glaucoma suspect patient, for example, it's a diagnostic for the glaucoma. Parapupillary choroidal atrophy, beta zone, I said, complete loss of RPE and diminished photoreceptors. It's a central zone of the RPE. Visible sclera and large choroidal vessels seen under the retina correspond to the absolute scotoma in the visual field. Myopic versus glaucoma. Larger and occur more in glaucomatous eye. The increase in size of the beta zone, as we said, this is one of the signs of glaucoma. For the parapupillary atrophy, the beta zone, width of the beta zone inversely correlate with the rim width at same area. Larger beta zone giving thinner rim. So progression of the beta zone associated with progression of the glaucoma. Changes which happen over time, either extension of the cupping, increasing shift of retinal vessels, nasalization, increasing the asymmetry of the cupping between the both eyes, the increase in the disc pillar, or presence of the disc hemorrhages. Diameter of retinal arterioles on the optic disc, diffuse narrowing, it's coming with the advancing disease, focal attenuation. If you do fluorescein angiography, it can show through stenosis. Finally, for the checklist, we usually in the examination determining the disc size, check for the unusual disc shape, as we said, for the oval shape or for the normal finding like tilting disc. Determine cup disc ratio, either size, relation of the cupping to the disc size itself. The disc size, is it large or big or small? Evaluate the rim shape, smaller rim width. Check for the nerve fiber layer defect in the red-free elimination. Look for the disc hemorrhages to rule out glaucoma in the normal suspicious. Another useful method to check for the 5 R's in the optic disc examination and nerve fiber layer. Whether it glaucoma or normal, use the 5 R rows. Observe the sclera ring to identify the limits of the optic disc and its size. Scleral rim. Identify the size of the rim, itself from the disc margin to the rim margin. Examine the retinal nerve fiber layer if any defect presents. Examine the region of parapupillary if there is any atrophic beta zone or increasing size of beta zone. Look for retinal and optic disc hemorrhages, which can happen, as we said, more in the open angle glaucoma or non-retention glaucoma. Differential of glaucomatous cupping like disc coloboma, optic pit, Morning-Glow syndrome, ion disease, stellar lesion, methylcoin poisoning, myopic disc, and tilted disc. Early diagnosis of glaucoma, careful assessment of the disc is probably still the best way of diagnosing early glaucoma. Thank you very much for your association.